Welcome to rePROs Fight Back, a podcast on all things repro. I'm your host, Jenny Wetter, and each episode I will be taking you to the front lines of the escalating fight over our sexual and reproductive health and rights at home and abroad. Each episode, I will be speaking with leaders who are fighting to protect our reproductive health and rights, to ensure that no one's reproductive health depends on where they live. It's time for rePROs to fight back. Today on rePROs Fight Back, we're going to do a deep dive into the Global Gag Rule. For that, I'm going to be talking with Bjorn Snyder, the Director of Public Policy at the Center for Health and Gender Equity Change. And I'm so excited that Bjorn is here, so thanks for joining me.
Thanks for having me.
So let's start at the beginning. So what is the Global Gag Rule and where did it come from?
Well, the Global Gag Rule comes from 1984 and from President Ronald Reagan, who announced this new policy in Mexico City at the Conference on Population and Development there. It's also called the Mexico City policy and has been historically. Advocates call it the Global Gag Rule. And in the Trump administration, as they've expanded it, they've rebranded it the Protecting Life and Global Health Assistance. For sort of ease of all of us, and we're advocates, we'll call it the Global Gag Rule. But it started in 84, and it's gone on and off with each Republican and Democratic president since then.
Global Gag Rule, it kind of is an example of what the policy does. So let's kind of talk about why advocates call it that.
Well, so the Global Gag Rule is a presidential memorandum. It's not a law. It's something that comes straight out of the White House, which is why it's identified with presidents rather than Congresses. And it's a policy that restricts who can receive U.S. money. It's not about what can be done with U.S. money. We have a lot of different laws and regulations and policies that go into that, but this is about who can get U.S. global health assistance. And historically, it's attached to international family planning funds, so that sort of $400 to $500 million investment in helping women and girls around the world control their fertility and have the families they want to have. It's one of our great global health programs, and it has, in Republican administrations, had this policy attached. And the policy says if you receive international family planning money, historically, you cannot provide, promote, counsel, refer, or advocate around abortion as a method of family planning. And unlike other places in U.S. law, we define abortion as a method of family planning in the Global Gag Rule, and it's defined as for the purposes of spacing births, and it only excludes abortion in the cases of rape, incest, and life endangerment. So any organization receiving international family planning funds cannot anywhere in their portfolios be providing counseling, referring, or advocating around changes in abortion laws as a method of family planning. The giant caveat is that this only applies to foreign organizations. Because it is a gag, it is about what organizations can say and do with anyone's money anywhere in their organization. It would be unconstitutional as applied to U.S.-based NGOs. So you and I, as U.S.-based NGOs, we could take U.S. money. We won't, but we could take U.S. money and go and with other people's funds be promoting abortion, advocating, doing whatever with other people's money. Because we're U.S.-based NGOs, it explicitly targets local, foreign, national, non-U.S. NGOs with this policy restriction.
That's also a really important thing that you mentioned there, that it's what you can do with other people's money, that there are already restrictions on what you can do with U.S. money, but that this goes beyond and it attacks what you can do with money that other donors are giving you to do things that are priorities for them.
I mean, so imagine your goal as an organization is to reduce maternal mortality in Uganda. You know that between 6 and 13% of maternal deaths in Uganda are caused by unsafe abortion. You're trying to address this. It's a high policy priority for you as an organization. You have money from other donors, private donors that you've worked with on grants over many years to sort of get that funding to support your mission. You're maybe working with another foreign government, someone who has this a priority. Maybe the Dutch government is supporting a program or some advocacy. You also get U.S. money for health systems advocacy or providing contraception at 20 clinics or doing a couple mobile units with HIV testing and contraception to get to far off rural areas. You're getting U.S. global health money there. If you continue to take the U.S. money, you can no longer do all the other things you were granted to do if they involve advocacy around liberalizing abortion laws, if they involve counseling and referrals. So it's a real attack on other donors, on individual groups' autonomy, and also sovereignty. In a lot of countries, this is a really important health issue. All countries, it's an important health issue, but it's a priority in many countries. And this is really the U.S. government saying, we don't care what your situation, your laws, or your policies are. This is what we want to buy you off from being able to do.
Makes a huge difference because historically the U.S. has been the largest donor for family planning assistance. So a lot of these organizations have to make a really tough choice to take a lot of U.S. money but refuse to provide services they think are important. I mean, this is a really hard trade-off for a lot of places.
Yeah, certainly a lot of organizations are put in a pretty untenable situation of losing important programming, losing their mission, or losing U.S. funds. And to be honest, I mean, this is what the White House wants. I mean, it wants to put them in this position of needing to stop doing things that are important to them because of the value of U.S. money. I think it's sort of important to note, again, that in the Reagan administration, the first Bush administration, the second Bush administration, this attached to international family planning money, it was incredibly destructive, but I think for certain people conceptually, they could understand. We don't want to give to family planning groups that also provide abortion as a method of family planning. It's not really how health systems work, and it's not how human rights work, but that at least is the sort of the tether that I think made it an easy political decision for politicians that identify as pro-life. What we know from the previous iterations of the Global Gag Rule, there is data that we've been able to go back and sort of look at. And health data and data on abortion is really hard to gather. So there's limitations. And we also have not, as a global community, gotten a lot of support or funding to really measure the impact. But the impact we do know, just from the last iteration in the Bush administration, is incredibly alarming, both for health systems and organizations, but also obviously on an individual woman level of sort of ability to access family planning, ability to access HIV testing, ability to access antenatal care. We know sort of in the last Bush administration, it prevented women and girls from accessing contraception as well as safe abortion that may have been consistent with the laws of their country, but they were still not able to access it. It has hampered HIV prevention efforts. It contributed to the closing of a lot of health clinics, and in particular obstructing rural communities' access to care, and I can sort of unpack that too. And I think most, sort of gallingly, because of the way that people frame the issue, is it was associated with pretty significant increase in abortion rates, which for people who understand what lack of access to contraception means, that's not a surprise. But I think intuitively for people who blindly support the policy because it's supposed to be pro-life, the idea that it would increase abortion and increase unintended pregnancy, and the abortion that it's increasing is unsafe abortion. And so that also means it's contributing to maternal death. And again, this is what we saw in the Bush administration. There's a couple sort of clear examples that sort of tell us how health systems work and how interconnected they are. And this notion that, frankly, we're seeing domestically now too, well, if we take money from this group, if we take money from Planned Parenthood, someone else will just provide those services. Like, no big deal. We'll just give the money to the good people that we like. The problem is that doesn't work in the United States, and it really doesn't work in rural areas that are highly underserved for health. So we saw in Ghana during the Bush administration. The Ghana Planned Parenthood is a member of the International Planned Parenthood Federation, IPPF. IPPF had a massive cut, about almost a 50% cut in their funding during the Mexico City policy in the Bush administration. That gets passed down to national level. The Ghanaian Planned Parenthood saw about a 54% cut in their funding. They had to close a huge number of clinics, mostly in rural areas where because they're expensive to run, they're expensive to get to, they're expensive to get supplies to. And so what you really saw is women in rural areas losing all access to health services, and not just like the place they go to get family planning, but that may also be the place where vaccines are administered. It may be their only opportunity to get condoms. It may be their only opportunity to get HIV testing, which again, I hate to draw the parallels, but is similar to what we saw in southern Indiana with then Governor Pence's attack on Planned Parenthood. You saw a real health services desert that supported a really huge outbreak of HIV because there was no place to get tested, no place to get condoms, no place to get counseling and services. So we saw that in Ghana with the Ghana Planned Parenthood. We also saw, this has huge implications for HIV, even when it was attached to just international family planning funds. In Lesotho, the last year of the Clinton administration, Lesotho was receiving about just over 400,000 condoms from USAID, as well as some Depo-Provera and IUDs. And the Lesotho Planned Parenthood Federation, again, is the only one with the sort of the network able to receive and distribute that number of condoms. Lesotho is not a large country. It's kind of the size of Washington, D.C. Like it's not big enough to have other organizations. And because the Lesotho Planned Parenthood was no longer able to receive them, their shipments were just suspended. So we went from 400,000 condoms to zero in the first year of the Bush administration. And at that time, 1 in 4 women in Lesotho were HIV positive.
These clinics are in places that it's not easy to step in and fill that role. So you often hear advocates of the gag rule say, well, we'll just fund other organizations, but you can't replace relationships with the community that these clinics have developed. Or in a lot of areas that are remote, you've seen a lot of groups developing really innovative things to reach people that are, really far from the clinic, whether that's, mobile service delivery or any number of things that just are not easily replaceable. So you're going to create this big gap in women's ability to access services.
Yeah. And on an individual woman level, a break in care is potentially catastrophic, whether it's there aren't condoms that week, let alone that year, or missing your Depo shot, missing your other contraceptive moments. That can be the difference between a healthy pregnancy and not, a wanted pregnancy and not.
So we've gone through 8 years of no gag. What has changed in that time? I know the Obama administration had a real commitment to investing in family planning and some other things. So, going from gag to no gag, what have we seen in that time?
That's such a good question, Jenny, because that's sort of one of the under-discussed catastrophes here is that the last 8 years in the Obama administration were spent with a new vision on global health. The administration did something called it had sort of a commitment to global health integration, and that included integration of health services, particularly HIV and family planning, but also maternal health, nutrition. How can we be providing people with what they need at single sites or single moments? How can we be not siloing the health services that people need? Some of the other there was something called USAID Forward, which was a new way that does have flaws, obviously, but a way of really pushing a slightly different view on how we do development. And part of that was requirements about how much USAID money went to local organizations, so not large multinational, not U.S. And that didn't work out perfectly by any stretch, but what that means is a huge amount of money went towards local organizations, groups that do not have constitutional protections for the purposes of the global gag, but also maybe have the language skills, the community involvement, the cultural awareness to be really effective contributors to life-changing global health programs. But you combine integration with local ownership and country ownership and a real focus from the Obama administration on women-centered programming. And the things that we saw as huge successes and movement in the right direction during the Obama administration are now setting us up to have much worse impacts from this global gag rule. And to also say that in the same period during the Obama administration, but also before, since 1984, since the beginning of this, over 40 countries have liberalized their abortion laws. So the U.S.'s impact on going against the national movement is much stronger now than it was before. We are dragging countries backwards away from their own health and human rights priorities.
This brings up to the giant elephant in the room, which is what has happened since the Trump administration took office on gag?
So the Trump administration, I think advocates knew that this was coming. It happens with Republican administrations. I think those who know Mike Pence expected what happened on January 23rd, which was a presidential memorandum that immediately reinstated the global gag rule as previously applied to that international family planning money, that around $500 million in international family planning money, but then also directed the Secretary of State to expand it to all of global health assistance. That expansion is very, very hard to overstate what that means. The U.S. is the largest global health donor in the world. It is, it's a minuscule, preposterous portion of our budget, but the good it's able to do around the world. We're currently supporting 11.5 million people on ARVs, so HIV treatment worldwide, and providing contraceptive supplies and commodities and counseling and support. I mean, there's a lot of really good work happening, and it is now all touched by the global gag rule. So the White House announced the expansion on January 23rd. The direction was to sort of figure out how far they could take it, essentially. It started applying to international family planning funds in March. That was the sort of the first part of the presidential memorandum. And the expansion and how it would apply to the rest of global health assistance was announced in May. One of the things that makes this a really tricky thing to advocate around and talk about is that it's a contract provision. There's not a big moment where everybody's in or everybody's out, where funding gets slashed, where there's not a big watershed moment for the most part. It is a contract provision that as organizations bid on new U.S. global health money or have new funding moments in their existing contracts or existing grant agreements, and then it will attach. And that sounds benign. It sounds small. It just sounds like, oh, this is like a contract thing. But what that actually means for an organization is when all of a sudden they are going to have a new dispersal of funds or a new moment in which they are signing something new with the U.S. government, they either are certifying that they no longer or have not or do not, they will comply, and so that they will not provide abortion as a method of family planning, provide counseling and referrals for abortion as a method of family planning, or advocate around abortion as a method of family planning. If they're a U.S. group, while they themselves can continue to do all of those things with other money, they do have to pass it down to all non-U.S. groups with the money. So it's like poison money, and it attaches to the money and then poisons every organization it touches. So that poison money started coming out of international family planning in March and started coming out sort of early summer and now into the fall in all of our other global health programs. And to really say that scope of that is about 15 times the pot of money that it has ever previously applied to. We went from 450 million international family planning funds in the Bush administration to $8.8 billion of global health money this year.
And that's billion with a B.
That's billion with a B. To really, I think, really hone in on the scope. So South Africa, which is one country, with a really complex and very, very challenging HIV epidemic, a priority country for PEPFAR, which is our President's Emergency Plan for AIDS Relief, which is our largest global health program committed to ending the global HIV epidemic, or at least doing the U.S.'s part. And PEPFAR money has been really, really important to South Africa. South Africa alone received $456 million in PEPFAR money this year. So one country is having the same amount of impacted money as all of the global gag attached to the last time.
That's crazy to think about. And we're still at a time when the maternal mortality rate is quite high around the world. And unsafe abortion accounts for not a insignificant amount of that. And so this pro-life policy, definitely in air quotes, could really cause a spike in maternal, maybe not a spike, but it'll have an impact on the maternal mortality rate by denying women access to contraceptive care, or if that group had really integrated their services and now had a maternal health clinic, an HIV clinic, all within one structure, and they decide that the best option for them is to refuse the U.S. money, that means these women are losing out on this whole spectrum of care that they could have been getting before.
And what we see is that, organizations are being forced to make terrible decisions and do the absolute best they can with it. And I think it's really important to note it's not signing the policy doesn't mean you agree with it. Groups are just being put in sort of untenable positions of how many people will lose what kind of care if we do this, how many people will lose this kind of care if we do this. Really balancing body counts, which is just a horrifying position to put healthcare providers, organizations, and sort of advocates in, is making that kind of call for external political reasons by politicians who are not accountable to the people that the policy hurts at all.
Absolutely. So I know there's been some preliminary research done, and again, like you said, this is kind of a contract, so it comes out in waves and it's not all implemented yet, but there have been some primary results we're starting to see as to what impact this expanded global gag rule is going to have.
Yeah, and to say, the limitations are, we're not going to get quantitative data for years and years. And that's the kind of data that says X million women lost access to contraceptive care, this many people died. That's very difficult data to get. And while it doesn't matter to everyone, it certainly matters to us. We want to make sure we're capturing things correctly. And before that, though, so we don't have that quantitative data. And frankly, we're still, as a community, working on mitigation of harm. We would rather get less terrible data because we did everything in our power to save people's lives and save people's health care, which I think is not necessarily something the White House understands. The goal of implementers is not to tell a story of catastrophe. The goal of implementers is to produce good health results and save people's lives. And so I think the majority of energy is going into that still now. I do think some of the early results, the two big foreign organizations that provide huge amount of reproductive health care services globally are the International Planned Parenthood Federation and Marie Stopes International. Neither of them can certify abortion as a human right, abortion provision as a core part of their mission as organizations, and they are unable and unwilling to certify. That right there just means a huge number of programs closing. MSI alone has really been a very important implementer for the U.S. government in the last 8 years. MSI's internal calculation of sort of what they have done with U.S. money, and if they are not able to replace U.S. money, what will happen in the next 4 years is very staggering. As a single organization operating globally, but with 4 U.S. contracts and grant agreements, but still just one organization. Their estimate for the 4 years of the Trump administration is that the Global Gag Rule will contribute to at least 6.5 million unintended pregnancies, 2.1 million unsafe abortions, and 21,700 maternal deaths. And that's just them.
I'm going to say, that's just MSI.
Yeah. And I think for people who don't understand healthcare, the idea that defunding an organization, no longer partnering with an organization could have that kind of impact just sounds crazy. But when you're talking about rural Madagascar, what it takes to create a clinic, what it takes to get health professionals there, to have community health workers that are trusted, to be able to really build the relationships needed for people to have the conversations about their most sort of intimate health needs, their desires. You can't really overestimate how much work goes into that and how challenging it is for them to be able to continue to do that work with other money. And so they will not be able to continue to do all of that work with other money. They're certainly doing their best to mitigate harm, but those programs, those clinics are going to close. And when women don't have access to contraceptives, there will be more unintended pregnancies. And when there are more unintended pregnancies, if women do not want to stay pregnant, they will not stay pregnant. And the result on that is usually unsafe abortion. And both pregnancies and abortion, unsafe abortion, we're talking about sort of backwoods, quack, do-it-yourself, anything that works or feels like it might work, or your sister told you it would work, or your auntie said it would work. Unsafe abortion and unspaced pregnancies both are major contributors to maternal mortality. So even though it's staggering to hear that 21,700 maternal deaths could come from the cessation of MSI services in the next 4 years, for people who really understand the risk of pregnancy and the risk of unsafe abortion, I'm afraid it's not a huge surprise.
You have to kind of shift your frame of mind of thinking, okay, rural in the U.S. means one thing, right? Like you have a car, you have to drive an hour, 2 hours to a clinic. That's kind of what you're thinking, but that's not at all what we're talking about here. In a country like Madagascar, we're talking really remote areas, probably with very little vehicle access, and certain times of the year, none, because of flooding or any other type of kind of natural obstacle that makes it really hard for women to get to clinics to access services. So if they lose their rural access to reproductive health services or just clinics in general, there's a really real danger that they're not going to be able to go somewhere else to access that service, so they just won't have it.
Yeah, and not to downplay the clinic deserts in the United States, because it's obviously a very, very serious problem as well, and the amount of energy that women have to go into to get bus tickets and schedules and, make it to a city 4 hours away is still a huge burden.
And we will definitely be talking about that at some on this show. So absolutely true.
Yeah, but I mean, you are talking about some other infrastructure challenges, communication challenges, and also autonomy challenges. I mean, we know that a lot of unsafe abortions globally are young women. We don't have great data on it, but we have really terrible anecdote on the correlation between sexual assault and then unintended pregnancy and then unsafe abortion for adolescent girls who are less likely to even be able to access the clinics, even if there are clinics that remain. Youth-friendly services is not just a buzzword. I mean, it's what makes it possible for young women who are not married, who might otherwise face stigma and financial challenges, to be able to access contraceptive care, testing, good information, the stuff that we know makes a real difference in people's lives. We've made some real strides on that adolescent-friendly stuff, but we're not there yet. I mean, it's still a big challenge. People have been working on what mobile clinics look like, what youth-friendly sites look like, and a lot of those are the ones most likely to be closed now.
So we talked about how the Obama administration really had an effort to localize services and to push grants out to local providers. And so you see, maybe that would mean sub-grantees from larger grantees being local providers versus just going through a larger international group or domestic group. Now these groups have to implement this policy on their grantees. How is this affecting relationships with NGOs and the people that they are subgranting to?
It is a lot of work and a lot of very unfun work. It's a even U.S.-based organizations that don't have to implement it themselves, it's a big administrative and compliance burden. The burden is put on people receiving U.S. funds, but also the prime partners, if you're sub-granting, to check on compliance. And so that really changes your relationship. And not to say, I mean, we have very important pieces of legislation around informed consent, around good practices in family planning that implementers are really used to knowing how to comply and also monitor compliance, and that's really important. So I don't want to suggest that sort of all compliance is a burden, but you're being asked to police everything every one of your subgrantees does with anyone's money. And for a lot of groups, we're in a time right now where they're getting their first contract that has this in it, and they're having to break off partnerships, long-standing partnerships, realizing that when they do that, that 20-person organization is just going to close. There's no alternative source of funding to their subgrantee, and they don't necessarily have another partner that they can find who has the credibility, who has the sort of meaningful relationships in the community, the language skills, whatever it is. It puts a big strain on the prime and sub relationships. But in some ways, I think the places that we see the sort of the toughest relational work is actually within the advocacy communities. We focus a lot on contraceptive access, HIV testing access, the sort of the hard, tangible supply and service provision, but this also wreaks havoc with advocacy, and that is a real intent to say that if you take any U.S. global health money, you cannot participate and do any advocacy around changes in abortion law, means that a maternal mortality coalition is going to be just splintered into pieces. Groups that take U.S. money will stop participating because you can't talk about maternal mortality without talking about unsafe abortion in most countries. And so maternal mortality groups that have been working on, the hard work that you and I do every day on talking to their members of parliament, their ministries of health, trying to push for better guidelines, better guidance, the hard work of advocating for clear, real access to abortion, even if it's in a very restrictive environment. That work requires collaboration, it requires trust, it requires getting stakeholders to see themselves reflected, and that's being really fractured. I don't know how that kind of advocacy is going to survive the Trump administration in 60 countries around the world, which is really, and to say again, that is the goal. That is the goal from the White House. That kind of havoc and undermining of civil society and health priorities is in fact their goal.
So talking about advocacy, that makes me think of the groups that have made that hard choice to decide that they really need to keep providing. Have we seen a chilling effect? I mean, that's kind of a little bit of what you're starting to get at, of groups being scared of even getting anywhere near abortion-related issues because they're afraid to lose their funding.
Yeah, and to say this is something that is pervasive with U.S. global health assistance because we do have some legislative parameters on what can and cannot be done with U.S. money. Between that and the on-again, off-again nature of the Global Gag Rule, there's a bit of a global narrative that if you take U.S. money, you can't do anything on abortion. And that was not disrupted by the Obama administration as much as it should have been. Yeah. But there are groups that knew how to work exactly within U.S. law, exactly within U.S. policy, how to navigate those parameters and still be able to do the work that they needed to do. The Global Gag Rule, especially in its expanded, because it's touching so many new organizations, I mean, we anticipate it's going to be touching well over 1,000 new organizations, probably well over 1,500. It's actually a really hard thing to calculate, and folks are working on it. But that's every new organization that's now having to start to think, oh my God, like what have we been doing? What can we do? And I think there's a real tendency to want to stay as far back from the line as possible, not be in the room for conversations about abortion, not go to conferences if it's going to be discussed. And USAID doesn't do anything to disrupt that. USAID is a very conservative by nature agency, and so they don't have an incentive to encourage people to work up to the line. They really encourage the chilling, the fear, even within their own staff. People are afraid to talk about the policy, let alone sort of talk robustly about what different pieces of it mean. And perhaps the most important thing that advocates can be doing is talking about what can still be done, talking about it in a proactive way rather than in a defensive way. It is so important, especially in countries that already have restrictive laws, for people and clinicians and implementers and USAID missions and other donors to know that you can still provide post-abortion care, that you can be providing abortions in the cases of rape, incest, and life endangerment, which may be the only legal ways to provide abortion already in that country, that you can be providing counseling and referrals in those circumstances, that you can be providing emergency contraception, which is actually a major conflation that's happening in some places because it was separately sort of sidelined during the Bush administration. And so a lot of people sort of think, well, if we're bringing back Mexico City policy, that must include emergency contraception, which it doesn't emphatically. And so I think really getting people and groups to focus on what they can and should still be doing is a really important piece of the on-the-ground work that needs to happen and will not happen by USAID.
Yeah, and I mean, it seems like an especially heavy lift this time around. Before it was the family planning groups and the Family Planning Bureau at USAID. They knew the drill, they knew what was covered, they knew how to do things, and now it's expanding to cover so many other bureaus and so many other groups that have never had to touch it before and are kind of having to quickly learn on their feet, hopefully.
Yeah, hopefully. Yeah, I mean, when we talk about global health assistance, the largest program is PEPFAR, the President's Emergency Plan for AIDS Relief. But this is also touching the President's Malaria Initiative, nutrition, maternal child health, all of the sort of pandemic work that we do. So it's a lot of new people, a lot of new actors who haven't necessarily had to give thought to this, particularly in the places where it actually runs up against their own medical ethics or their own law. I will say, this is a pretty wonky side bit, but the expansion does include an affirmative defense that if you are required to provide counseling and referrals for more than just the 3 exceptions by your law, you can continue to do that and won't be considered to have violated the Global Gag Rule. And that sounds super wonky, but it's incredibly important because there's at least one country and potentially a couple others where you have an affirmative obligation to provide counseling and referrals for abortion in a variety of cases larger than rape, incest, and life endangerment. And if you weren't going to if you did not provide them as a healthcare provider, you would actually be legally liable. So we were setting up entire countries worth of health providers to violate their own law and basically putting them in a position where they would have had to face their own clients and their own courts saying the United States government paid me to violate the law, which is an untenable position and a really morally reprehensible one. But it's very, very important for those providers, clinicians, implementers to really feel well-versed in this. Again, it's a contract provision. It's not sexy. There's not good guidance. It's hard to understand. And understanding it is not the primary aim of most of these groups. Their primary aim is nutrition or getting antiretrovirals to rural areas, hard work that is their actual mission, and they are not necessarily well-versed in U.S. contract law.
So, speaking of law, I know that you also happen to be a lawyer, so if you could switch and put your little lawyer hat on, if we can talk about, are there any legal options to try and attack this vastly expanded policy?
Not silver bullets. This is a particularly tricky place in U.S. law because the people impacted are not constitutional rights bearers as far as the U.S. court system goes. So there have been a number of court cases launched in the past 30 years. None of them have been successful. They have not been winning fact patterns in a couple different districts. I would say we have very smart people within the U.S. community looking at what a challenge might look like, but it's not going to be a silver bullet. It's going to be about U.S. stakeholders, which is, an incredibly tough thing to think. Like, we know that women and girls' lives are going to be lost. We know that health systems are going to be upended. We know that national priorities are going to be undermined, and none of those things are things we can sue about. So there is thought going into it. I hope, maybe in 2 years we can have a different conversation, but I think there's such a sense sometimes, especially right now in the U.S., that like something wrong is happening, something terrible is happening. Can't the courts step in? And unfortunately, because of who is impacted, who and how they are impacted, and how the policy is written, there isn't sort of a slam dunk court challenge.
That's unfortunate, but hopefully we can see some progress moving forward. So I really like to end all of my shows on a hopeful-ish or positive note, or at least action-oriented. So now that people are aware about this terrible policy, what can people do? What actions can people take to make a difference?
Really important question, both for morale, but also practically speaking. It is a policy that ruins people's lives that don't get to vote. So I think for a U.S. audience, it's really important to know that we're doing this, that it's being done in our name, and talk to people about it. It is not something your members of Congress are hearing about a lot, except from people who say, well, it's pro-life, and we want you to be pro-life, and we're pro-life, so support it. And that's an incredibly superficial level of thought for something that has so much impact on so many people's lives. So I think the most important thing is just putting it on your priority list. And I know we all have activism fatigue right now, and we're focused on saving U.S. clinics and doing other really important work. But just leaving a tiny sliver of your outrage for this notion that we're exporting an otherwise unconstitutional, really, really problematic, incredibly destructive policy for people to be able to win political points in the U.S. and never have to see the catastrophes they're causing. So talk to people about it is always a good start, and it's a basic start, and it's an easy start. There is a piece of legislation called the Global Her Act. It was introduced the day after President Trump did his presidential memorandum in January. It has an unprecedented number of co-sponsors and is bipartisan in the Senate. It's called the Global Her Act. It legislatively ends the Global Gag Rule. So it takes it out of the executive and says this is not a thing that can flip back and forth. It is permanently ended. I think supporting it, letting your members of Congress know that you want them to support it is a really important opportunity. But, if you're sitting in Kentucky or maybe northern Wisconsin or West Virginia right now thinking my member of Congress is going to vote pro-life no matter what, and there's no way they're coming on this bill, I actually think this is like an amazing opportunity, again, to disrupt that narrative that this is a pro-life policy. This policy is absolutely associated with increased abortion and increased maternal death, and your member of Congress needs to know that. And so calling them and saying, I know you support the Global Gag Rule and think you're pro-life, but this policy is not pro-life, is a really important message for them to hear from as many of their constituents and constituencies as possible. They are right now they support it because they've heard from some churches that say that this is pro-life, and it's not. And so even if they are members who truly are people of conscience who think they are doing the right thing, even if we know that that's not necessarily true, it's really important for them to know that it's not the right thing. It's not pro-life. It's not reducing abortions. It's not saving women. It's not anything that's important in their frame. It's not actually doing that. It's inefficient, and it's increasing negative health outcomes, and it's increasing abortions.
And I can't overstate how important it is to call your member of Congress, particularly on an issue like this, they're not hearing from people on this. No. And it won't take very many phone calls for this to get passed up and to get looked at. So if 10 of you call your one congressperson, they're going to take a second look at this. This isn't like healthcare in the U.S. where you need a large number of phone calls. You only need a couple on something like this.
And again, a couple to make them look a little more closely, a couple to make them ask some questions. They're really not giving it thought right now. And the lack of scrutiny from U.S. policymakers on something that is catastrophic to health systems globally is very disheartening as an American voter. And I certainly want to make sure that my members of Congress are looking really closely. And even if they're incredibly anti-choice members, I want to dampen their enthusiasm for this policy. I don't want them to feel like it is a political win with no repercussions, because it has horrible repercussions for women and girls around the world, and they at the very least need to know that.
Well, thank you, Bjorn. This has been a great conversation. On our website, under show notes, I will have links to all kinds of things about Global Gag Rule that you can check out. So thanks for listening, and thank you so much, Bjorn, for being here.
Thank you for having me.
For more information, including show notes from this episode and previous episodes, please visit our website at reprosfightback.com. You can also find us on Facebook and Twitter at reprosfightback. If you like our show, please help others find it by sharing it with your friends and subscribing, rating, and reviewing us on iTunes. Thanks for listening.